All right. Uh, I often find this hyponatremia as a puzzle. And this format is entirely my own. It just came from my mind, and I just made 6 steps. I'm not sure how workable they would be and how useful they would be, and will that make your life easy or more complicated, but I'm going to present it. The audience, I think, in my mind is, I think, younger doctors who treat critically ill patients, hospitalized patients, and also the senior physicians who see patients, elderly patients, and when you go through their report, you notice hyponatremia. Patient has got multiple symptoms and not attributable to anything, but you notice hyponatremia. I think they're relevant to them also. So this is called a 6-step approach to the diagnosis and management of hyponatremia. The spectrum of the problem, it could be very simple and straightforward case, and the solution may be simple. Somebody with diarrhea and vomiting comes, and you do the routine lab, and sodium is low. I think the treatment is, you know the cause, and you know what to do. But on the other hand, we see sometimes somebody who has unexplained etiology with no clue to the diagnosis at all. He is not having any diuretic, and but just through the reports, you notice that there is hyponatremia. And then we have all grades and shades of the problem, often complicated by multiple comorbidities and multiple medication. So it might not be easy to put your finger to which drug is causing or which disease is causing, or the multiple of them. So I think that is why this becomes a puzzle, and I'm trying to suggest a algorithm which will hopefully help you to solve this puzzle. So these are hypothesized 6 steps. They may not be done in the sequence I'm going to mention, and most of the emphasis would be on step 1. The tempo which I move, don't think that I'm going to take equal time. I think most of the time will be spent on step 1, and the rest of the steps will be relatively easy. So what is the step number 1? To identify and confirm hyponatremia. Step number 2, assess volume status. Extremely important. You cannot interpret hyponatremia unless you know the volume status. And third is determine severity and duration of symptoms, because this has got bearing with the time, the treatment. And fourth step is monitor for correction rate. Step number 5, specific management based on the cause. Of course, the first step would be to correct hyponatremia, but follow-up treatment would depend what is the cause, so you will have to address the cause also. And the 6th step is address underlying causes and long-term management themselves. So these are the 6 steps. Let's take up the first step, identify and confirm hyponatremia. I think whether you suspect or you just do the routine laboratory, you have the report and the sodium is less than 135, and that is formally hyponatremia. I think if you are treating a complex case, it is always good to have complete biochemistry, at least glucose, blood urine nitrogen, protein, and lipids. And I'm going to show you why these things are important in the diagnosis and interpretation of hyponatremia. This is called translocational hyponatremia. Now, what happens is that there is accumulation of some solute in the body which is not sodium, like glucose or urea. So they increase the osmolality, as shown by the green arrow. They increase your osmolality, and osmoreceptor detects it, and as a result, intracellular fluid comes out. You know, sodium just can't move freely because sodium is controlled by sodium-potassium pump, whereas water can go this way across the membrane, and intracellular sodium comes out, and as a result, serum sodium drops. So this is, truly speaking, hyponatremia, but actual total sodium contents in the body are okay. So this we have to rule out. In this case, if there is hyperglycemia or increased blood urea, nitrogen or the other cause I'm going to show you, they need to be addressed. You may not do further workup to find out the cause of hyponatremia. Another situation is what is called pseudo-hyponatremia. This is becoming less important because new machines, they detect sodium, but the previous machine, they sometimes, if there is a presence of some solvent, in the previous example, I mentioned some presence of a solute, but in this case, presence of a solvent like triglycerides or alcohol in people with alcohol binges. So the sample you take is actually not entirely plasma itself. It's not the water part. There is some fat, some other things which does not have sodium. So you are measuring sodium in the total sample, but the actual concentration in the water phase of the plasma may be normal. So this would be called pseudo-hyponatremia. And again, you have to find the underlying cause. You might not wonder about the hyponatremia itself. So once you have ensured that you're dealing with true hyponatremia, then confirm osmolality status. There are two ways. One traditional way is to use this formula. Measure sodium and multiply it with 2. Why 2 multiplied with 2? Because sodium is a cation and we have as many anions as we have cations. So I think total ions, they're all osmotically active. Then glucose divided by 18 because we want glucose in millimoles. And these days, many laboratories would report glucose in millimoles. So in that case, you will not need to make this conversion. BUN to be divided by 2 by 8, again, if it is given the milligram, because we want to convert into millimoles. So 1 millimole exerts 1 milliosmol pressure. So I think this is how this formula works. But other factors, if present in the blood in some patients, they would also contribute. So this assumes that nothing else is present. If you want to measure osmolality more accurately, these machines are available, so you could do that. So serum osmolality needs to be measured in a patient who has hyponatremia, and that will lead you to further guidance. So there are three situations. One is that there may be hypertonic, like serum osmolality more than 295 milliosmoles per kg. This would be called hypertonic. So if you have hypertonic state in a patient who has got hyponatremia, you must suspect something else which is causing this hypertonicity, and that could be glucose or mannitol. Somebody just underwent some procedure, or contrast was injected of methanol poisoning or ethylene glycol, or alcohol also. So this is hypertonic. So this is not true hyponatremia, okay? And the second is when osmolality is within the normal physiological range, this would be called isotonic hyponatremia. And in this case, if there is hyponatremia, that is pseudo, because this presence of lipids or proteins, but the modern machines, they measure it with what is called substance-specific electrodes. In that case, they would ignore these protein and other things. They will just measure sodium. So I think pseudo-hyponatremia will be applicable only when you are measuring sodium with the older machine, the flame photometer. And the true hyponatremia is when there is hyponatremia with decreased osmotic pressure, hypotonic hyponatremia. That is true hyponatremia. And in this case, further tests to be done to determine the exact cause. So my further discussion would be focused on this true hyponatremia. So in that case, I think you should measure urinary sodium and urinary osmolality. And based on that, if you measure urinary sodium, if it is less than 20, that means it is depletional. That means if there is actual deficiency of sodium in the body, kidneys must be very efficiently trying to preserve every single molecule of sodium passing through the nephron. So sodium is reabsorbed. That means urinary sodium concentration must be low. So that is depletional. That means total is body is actually deficient in sodium and you probably need to replace it. But if it is more than 30, that means that it is dilutional. Kidney has lost the ability to get sodium back. Although there is hyponatremia, kidney should get the sodium back, claim back, but it is not able to. That must be because of some intrinsic disease of the kidney or some problem with the other hormone. Like it may be a case of syndrome of inappropriate ADH secretion. There may be unphysiologically high level of ADH, or there may be reduction of corticosteroid because they also regulate our sodium, and there may be deficiency of thyroxine. So these conditions would cause hyponatremia and also lead to increased sodium contents in the urine, at least not reduced content. So, and then we check urinary osmolality. If it is less than 100, this would be this cause of psychogenic polydipsia. This is a condition which comes in the differential diagnosis of diabetes insipidus. People, because of some problem with their thirst mechanism, they drink too much water. So the primary problem is polydipsia, but they then excrete too much water. That results in polyuria. As a result, they develop hyponatremia because they're drinking pure water. They're not drinking salt. So they end up having hyponatremia. In this case, urinary osmolality will be less than 100 because they're passing dilute urine. But if there is increased urinary osmolality, that means ADH activity is high. It could be due to abnormally high syndrome, this ADH, or physiologically high ADH, like in a state of dehydration. So I hope this is making some sense. So if somebody has increased urinary sodium more than 30, and there is increased ADH level, this would indicate dilutional hyponatremia due to syndrome of inappropriate ADH secretion, or due to hypocortisolism, or due to hypothyroidism. Hypocortisolism and hypothyroidism, they have their unique clinical feature. They may be easy to rule out, but I think syndrome of inappropriate ADH secretion is a very, very tricky situation. So I think ADH activity would cause some concentrated urine. So this leads me to the syndrome of inappropriate ADH secretion. I think anybody who has unexplained hyponatremia, you must always think of syndrome of inappropriate ADH secretion. And how does it cause hyponatremia? There's underlying cause. There is abnormal production of ADH. Some tumor, or there is a list of many conditions, there is abnormal production of ADH, and that is retaining water. And the water is retained, and that leads to expansion of extracellular compartment. Although this is classified as euvolemic state, but actually extracellular compartment slightly expanded, you don't have the clinical features of volume overload. And this would lead to hyponatremia. And once there is expanded extracellular compartment, RAS will be suppressed, and that would increase sodium excretion because it is not retaining, and urinary sodium is increased, and urinary osmolality is also increased. So intracellular water is shifted into the extracellular compartment, but no obvious clinical features of volume overload. So you wouldn't have edema feed, you wouldn't have engorgement neck veins, you wouldn't have effusion or ascites. And that's it. We call it euvolemic, but actually fluid is slightly in excess. So if you have combination of these, hyponatremia confirmed, pseudo-hyponatremia ruled out, translocational hyponatremia ruled out, true hyponatremia, but increased urinary sodium and increased urinary osmolality, it is very likely that you're dealing with a case of syndrome of inappropriate ADH secretion. So if that is the case, then you will have to go through the long workup. I think based on common sense, you can start from anywhere. I think since the commonest cause is cancer, and the commonest cancer which causes syndrome of inappropriate ADH secretion, I would probably start from X-ray chest. But the symptom could be related to neurological problem, acute stroke, brain surgery, pulmonary causes, pulmonary edema, lung trauma, neoplastic, medication. I think medication is extremely important, and in some cases, idiopathic. Despite all the tests, we fail to find the cause of hyponatremia. In some cases, it may be actually appropriate hyponatremia. Their set point in the brain is set at a low level. For that given sodium is appropriate for them. So review the medication, very important. I think if you have unexplained hyponatremia, please go through the investigation, go through the medication patients taking, and not necessarily diuretic. There are some drugs not diuretic, but they may cause syndrome of inappropriate ADH secretion, and then maybe total body imaging. So differential diagnosis of syndrome of inappropriate ADH secretion is hypoadrenalism and hypothyroidism. In some cases, they may be misdiagnosis, but actually I think they have their own unique clinical feature. They should be easily identified and their clinical presentation is different, and then relative lab data that test should be done and treated. So this was part one, and now we're going to talk about the second part, very important, assess volume status. In volume status, of course, you can have three situations: hypovolemic hyponatremia. This is likely to be the commonest situation, or you could have euvolemic hyponatremia. As I mentioned earlier, it is called euvolemic as far as clinical examination is concerned, but actually these patients may have slightly volume overload state. And then hypervolemic hyponatremia, which means that clinically there is evidence of volume overload. So hypovolemic hyponatremia, when you're actually losing water and salt, you're losing more salt than water. So that is why you end up having hyponatremia. So the losses could be from the gastrointestinal tract, maybe from the kidneys, or maybe from the skin. Or euvolemic hyponatremia, the best example is syndrome of inappropriate ADH secretion or psychogenic polydipsia. In both, there is slight expansion of extracellular compartment, but then it is adrenal deficiency and thyroid insufficiency, and this volume may be actually slightly contracted, but all these are classified as euvolemic hyponatremia. Then we may have hypervolemic hyponatremia, like patient with heart failure. They have all the features of volume overload, patient with cirrhosis, patient with renal diseases, renal failure, nephrotic syndrome. So based on this, I think you will put hyponatremia in one of these three categories. If it is hypovolemic hyponatremia, symptoms and signs of dehydration are easily discernible. And the treatment would be, I think, simple, straightforward, IV fluids and IV or oral fluid and sodium replacement. If it is euvolemic hyponatremia, I think clinically no evidence of dehydration or volume overloads. This would be a tricky situation. So you have to figure out the cause. I think in this case, if it is syndrome of inappropriate ADH secretion, our first step is usually water restriction. So water restriction, and sometimes we have to add furosemide, sometimes we have to add some salt, but based on patient, I think we tailor our treatment. And those patients who have hypervolemic hyponatremia, there may be already known cases of heart failure or cirrhosis or nephrotic syndrome. So I think the diagnosis may be relatively easy, but they are taking multiple drugs. So you don't know if it is the disease which is causing this hyponatremia or is it the medication. So because you have to know the cause, only then you will be able to address. So management would be water restriction and then salt supplementation. Of course, the treatment will vary from person to person. So this was the step number 2. And now let's take the step number 3, determine severity and the duration of symptom. This is again a very, very important. Severity, if it is more than, if it is within 130 to 135, it is very mild and maybe mostly asymptomatic. Moderate is between 120 to 129. Again, patient may be having some non-specific symptom, lethargy, drowsiness, or some sleep disturbance, or if it is severe, it's very likely to be symptomatic. Patient may be having fits or may be unconscious. So hyponatremia is actually potentially very, very serious disorder if it is severe. Second thing is duration. If it is less than 48 hours, it is acute. If it is more than 48 hours, it is chronic. Very important. This differentiation is very important. And in some cases, it may be of uncertain duration. If it is uncertain, where would you put it? In chronic or acute? Yes, I think the safer approach is to put it in the chronic, because chronic hyponatremia has to be treated differently. In comorbidities, heart condition, renal disease, and others, because they would also require your attention while you replace sodium. So the third point is also taken. Now let's take the fourth step, monitor for correction rate. Now it would of course depend on the severity of hyponatremia, how the symptomatic patient is, and also the duration of hyponatremia. If it is mild, just monitor and treat underlying condition. Patient has come with vomiting and diarrhea. If you treat the underlying condition, I'm sure body has got a lot of capacity to correct mild hyponatremia on its own. Of course, some water and salt may be given. If it is moderate, initiate normal saline without diuretics. I think normal saline is good enough, because when you're replacing normal saline, you are actually giving slightly hypertonic fluid, because patient is Hyponatremic, patient is hypotonic. So you are correcting the hypotonicity by giving normal saline. So normal saline is very, very safe. You have to rule out background heart disease. That is why important to know the comorbidities. Sometimes if you think that you want to give sodium but not too much water, you may add furosemide. And that this is important. The severe hyponatremia has to be treated very, very carefully. Hypertonic solution is available, but in Pakistan, I think it's not freely available. Maybe those centers, the patient deal with these, those centers which deal with the serious patient, they may have, but in most of the hospitals, it's not available. But be careful, don't overcorrect. I know my time when I was young, I think a young physician tendency is to correct whatever is correctable. And the tendency is to correct it as fast as possible, because that gives you a heroic feeling that you fixed this problem. So I think just 1 or 2 or 3 boluses max, and at a very, very low rate, avoid rapid correction, no more than 8 to 10 millimoles per liter increase in the first 24 hours. And there is a very, very good reason why you have to go low and go slow. And I'm going to show you this. This is our neuron. In chronic hyponatremic state, both intraneuronal and extraneuronal sodium is reduced. Okay, so sodium is low within the neurons and outside the neurons, and a new equilibrium is established. But once you correct extracellular sodium and you do it fast, then extracellular sodium will go up. Sodium cannot enter neuron easily because there is a check mechanism, whereas intraneuronal fluid will come out. So as a result, the neurons will shrink. And the most sensitive part of our brain is brain stem. Once neurons shrink, many of them may die. The myelin sheath may be affected, and many of these neurons might die and might end up having this very serious complication called osmotic demyelination syndrome. Next day, you may find a patient who is quadriplegic or paraplegic, is not breathing. So that, of course, is something that you don't want even occurring once in your life. So don't be so fast in correcting severe hyponatremia, especially if it is chronic. So I think we were coming to the end of my presentation. Then specific management based on the cause. If it is heart failure, kidney disease, chronic liver disease, drugs, malignancy, intracranial condition, cortisol, CTI, thyroid hormones, it just based on common sense that you take appropriate steps to address the underlying cause based on the condition. And the last, address underlying cause and long-term management plan. You address the underlying cause. So if it is nutrition deficiency, I'm not sure how frequently you see. I see these patients quite often, elderly people who are taken care by the nurse or somebody else. They may be having hyponatremia just because they are not taking enough sodium. They're not taking enough diet, maybe due to malnutrition, maybe because of poverty, and many times just because they're not aware. So, and the treatment may be simple salt supplement. You could do it in the diet, and many times I've seen, in fact, people can't take large amount of salt. These people who the food intake is reduced, sometimes we have to prescribe them salt capsules. In syndrome of inappropriate data secretion, remove the cause if possible. Very importantly, go through the medication list. I think I never found anything more rewarding than just taking some medicine off and fixing the problem. So I think go through the list of medication patient may be taking, and of course you will have to give a replacement. Water restriction and Veptans, not available in Pakistan, but in syndrome of ADH secretion, you could give them there. They antagonize the effect of ADH. Use of diuretic and other medicine judiciously, and if somebody is taking diuretic unnecessarily, somebody prescribed a diuretic 5 years ago and patient never stopped taking, and that will be removed. So I think that can be done. Monitor sodium periodically. So these are all 6 steps, and let me present the summary. Hyponatremia is common and often overlooked electrolyte abnormality. Like, we are all concerned, very much concerned about hyper or hypokalemia. But I think we're not as, at least this is my impression, we're not that much concerned about hyponatremia. Acute hypovolemic hyponatremia is easy to diagnose and treatment, but chronic hyponatremia, especially in elderly, may be due to inadequate intake, and the simple solution is to supplement, and often complicated by diuretic, and the solution may be taking them off diuretic. Rule out pseudo and translocational hyponatremia before you start extensive workup to find out the cause of syndrome of inappropriate ADA secretion, and refer to the internet. I don't imagine everybody knowing about every drug. You find it surprised, go through the internet, ask ChatGPT if this drug is known to cause hyponatremia. Syndrome of inappropriate ADA secretion is the most challenging condition to diagnose and manage. Consider hypocortisolism and hypothyroidism in the differential diagnosis if it doesn't fit in anywhere. Thank you very much. This is all. I hope this algorithm would give you some outline how to tackle this difficult situation. Thank you very much.